It's always a privilege to be coming to Cairo. And unfortunately, for the last year, and obviously for this year as well, it has not been possible, and the numbers are rising again. So it's unlikely that it will be possible until next year, but I promise you I'll do all my best to come and present you a lecture next year face to face. Right, I've been privileged to work and come to Egypt with Robert Edwards. And from the very beginning of our working relationship, he told me, you have to look into the side effect of IVF on pregnancies, fetal complications, placental complications, because from the very beginning, he had been attacked by people who were against IVF about the risk of the babies being abnormal because of the artificial procedure. Now, we all know about these chromosome abnormalities and the risk of some fetal malformation associated with IVF and the RT in general. But what I will focus today, because these are still very controversial and the risk is very small, is placental and cord anomalies. So the impact of an IVF technique can be either congenital, leading to placental and cord anomalies that start from implantation, or they can be secondary with abnormalities of the placental development and function. So let's start with the congenital anomalies because we have much more data on this. And in particular, the incidence of placenta previa, anomalies of placental shape and form, anomalies of the umbilical cord insertion, and placenta accreta spectrum. I've put a question mark here. You will understand during my lecture why I have done this. There is absolutely no doubt that there is an association between placenta previa and IVF. You see, this is one of the early large studies from Scandinavia, and they put the risk at 28 weeks to be 1.6%, which is about 3 times what you will find in spontaneous conception. And this is the incidence using the standardized transvaginal scanning report from the American Institute of Medicine, which finds about 1% of placenta previa at 20 weeks. You see it drops around 28, 30 weeks to about 0.5%. So 1.6% is 3 times what you expect to find in spontaneous conception. Of course, you have to be aware, and I'm sure that you all know that the risk of placenta previa at 36 weeks is much lower as the lower segment is going to form and the placenta is not fully covering the cervix, the internal loss of the cervix. The lower segment actually will take away the edge of the placenta from the opening of the cervix. So, but still, I mean, when we do the scan at 20 weeks and we identify placenta previa, we obviously do a follow-up at 28, 30 weeks, and that's what you're going to find in IVF pregnancy. This was confirmed by another study the same year, which showed that independently of the high rate of multiple pregnancies, there is a higher incidence of placenta previa after IVF. Now, further studies have followed. This is another large study which showed that the risk of placenta previa increased depending on the endometrial thickness before the embryo transfer. So if you have an endometrial thickness that is over 12 millimeter, then you have one of the highest rates of placenta previa. And so a thinner endometrial thickness before the transfer seems to be associated with this lower risk of having a placenta previa. And these differences remain significant after adjusting for parity, smoking, or endometriosis. The only issue I have with these studies and all the others that will follow is that it's not clear when they mean ART, all these were IVF pregnancies or they included ovulation, induction, etc. And how did they diagnose and at what gestation placenta previa, and was this confirmed at delivery? This is always the big problem in these studies. This is another one that's coming from the US, American Journal, from Nordic countries, but published in the American Journal. You see here the report of risk of placenta previa in ART of about 4 times the normal rate. Again, don't know if they're all IVF, What about different type of fresh versus frozen embryo transfer? Again, no indication on when and how the diagnosis of placenta previa was made. Then there is this very recent study published in Human Reproduction, which shows that fresh blastocyst transfer is associated with a high risk of placenta previa compared to spontaneous conception, and to fresh cleaver stage transfer in singleton pregnancies. So again, maybe the technique of IVF can have an impact on the rate of placenta previa, but again, this study shows absolutely no data on how placenta previa was diagnosed. We did a review a couple of years ago, and it shows that indeed, if you look at all the big studies, including systematic reviews and meta-analysis, here this one included 161,000 ART. Again, ART, no specific data on IVF, but overall across the board, there is definitely an increased risk of placenta previa by about 3 times the normal rate in pregnancies resulting from IVF compared to spontaneous pregnancies. And again, you have to put that into the equation, and that will become very important in the context of placenta accreta, that you can almost double that risk of 3 if the patient has had a previous cesarean section before having the IVF treatment. So what happens here? Well, we don't really know, because IVF specialists transfer the embryo as deep as they can closer to the uterine fundus. But obviously, the interaction of this transfer blastocyst is not the same as the blastocyst that enters through a spontaneous conception via the tube. And so maybe this lack of interaction can explain why it implants later and lower. It could also be combined with change in intrauterine flow, because these flow are known to change during the cycle, with a flow going downward in the second half of the cycle, which is obviously around the time when the blastocyst is being transferred. The contractional uterus may also change during the cycle. So this could explain why there is a high risk of having your blastocyst implanted much lower than you would have on average after spontaneous conception. What about anomalies of placental shape? This is less obvious than placenta previa, no doubt. I could find this study published some time ago, which shows that you can have a placenta succenterata, which means that you have a separate cotyledon. In this case, 8.5%, but only 47 cases. So that's only very few cases. It's 4 cases had a succentral lobe after IVF. So that evidence is obviously limited. What about bilobate placenta? This is an important finding because it's often associated with a type 2 velamentous cord, which can link to vasa previa, which I will show you at the end of my presentation, or a previa lobe, as in this case. And the evidence is slightly stronger than just for the simple placenta succenterata. In 2012, Salafia and al. Were the first to identify a relationship between IVF and bilobate placental shape. This has been investigated recently. Another study showed that female gender was associated with bilobate placenta after IVF, and then frozen embryo transfer increases the formation of these accessory lobes, the previa lobe that I'm showing you here, compared to fresh embryo transfer. So stronger evidence and linked to some of the IVF technique, more specifically frozen versus fresh embryo transfer. Anomalies of the umbilical cord are something different, of course, but linked also to IVF, as you will see in a minute. It's important to identify them because a velamentous cord will be associated with a vasa previa. 90% of women who have a vasa previa will have a velamentous insertion of the cord. And then 3 to 4% of these BCIs will present with a previa. So a direct link between the two. And that we're talking, of course, about the cord being implanted outside the normal placental mass and connected to it with a vessel that can be a vasa previa when inserted in the lower segment. So you have the type 1, which is defined by this one, and the type 2, when you have a bilobate placenta, for example, with the cord inserted between the two lobes, and then you have vessels running in the membranes that connected these lobes. Undiagnosed vasa previa is associated with a 60% mortality at birth, and is responsible for about 150 stillbirths per year in the UK, which is huge. There's scandal in the press here when 10 babies die from Streptococcus B in one maternity, and here we're talking about 15 times higher death rate throughout the UK. It's much more common, of course, in twin pregnancies, and monochorionic twins have twice the risk compared to dichorionic, so these are really the target when you have twin pregnancies resulting from IVF. There has been a systematic review which included 569,000 patients. And so you see that the ART conception, again, they didn't divide it between general ART, IVF, IVF with ICSI, frozen, etc. But ART conception are associated with a 19 times risk of bilobatus eccentric placenta, VCI, or low inserted courses. So one way or another, you are much more likely to have an anomaly of the placenta shape or the insertion of the cord after IVF. A recent study has shown that marginal cord insertion is more common in frozen than in fresh embryo transfer. So again, the impact of the IVF technique, and this, of course, can lead to more velamentous cord insertion, which is much rarer, of course, than having the cord marginally inserted, which is not really a major issue for most deliveries. So why does this happen? We started studying this about 30 years ago when we first noted the high incidence of marginal and velamentous cord insertion, and my colleague in Belgium started collecting the data that I had in the lab and link it to IVF conception. And overall, we found indeed from the very beginning that there was a risk of velamentous cord insertion vasa previa, due probably to a malrotation of the blastocyst in IVF, which is much more common. So it's not only that the blastocyst will tend to implant lower and be responsible for more low-lying placenta previa, but also it tends to malrotate when it implants, again, because of different interaction with the endometrium lining the uterine cavity at the time of transfer compared to spontaneous conception. So a little talk about placenta accreta. I did put it separately at the end of this first part of my presentation, because I'm not convinced from the evidence I have seen that there is a direct link between IRT, IVF, and placenta accreta spectrum. The reason being that you see the wide discrepancy in results. This is an epidemiological study. This is a cohort study, and this is a systematic review. Now, what happens, of course, if you look in details at these data, is that, yes, you have the embryo transfer, which increases the risk of placenta previa, but you're also dealing with a population which has a higher rate, even in most European countries, of having had a cesarean section in their first pregnancy, which has an impact, of course, on both placenta previa and the risk of having the blastocyst implanting inside a previous cesarean section scar. And then you have advanced maternal age. So these are women who might have had hysteroscopy, DNCs, and other surgical procedure, minor surgical procedure of the uterus, which increases all the risk of placenta accreta. So I'm not convinced that there is a direct link between the IVF procedure itself and the risk of placenta accreta if you start removing all these confounding factors. Also, the studies that I found are so poor quality in terms of confirming the diagnosis of placenta accreta before delivery or at delivery or by histopathology, that I take these data with a big pinch of salt. Right, finally, what happens to the placenta in terms of its function, which I've been calling secondary anomalies. There is an increased literature now coming out showing that there is a high resistance to blood flow, a maldevelopment of the uteroplacental circulation, a high risk of small for gestational age. This study showed that it was higher in fresh than in frozen. So again, a link between IVF technique and especially fresh versus frozen. A study published this year, large study, 87,000. There was a higher mean birth weight of gestation among boys from 33 weeks and 34 weeks among girls. A greater risk of large for gestational age, so over the 90th centile, which we call the macrosomic babies at term, and lower risk of small for gestational age in frozen compared to fresh embryo transfer. So it seems that really freezing the embryo improves the development of the placenta. Now, I have no link to companies that provide a service of freezing embryo or the equipment that is required for this, but it's in the literature, if you look at this recent paper as well, favors embryo freezing when it comes to secondary anomalies, but also to primary anomalies of the placental development. So this is another study that confirms this. Another recent study has compared fresh and frozen and found that fresh is more likely to be associated with subchorionic thrombosis and fetal vascular malperfusion. And then this study from spank mouse also showed that fresh embryo transfer, blastocyst transfer, is associated with a higher risk of placental rupture compared to spontaneous conception. So in conclusion, we can say with strong evidence that IVF-ICSI increases the incidence of placenta previa and velamentous insertion of the cord, with therefore a higher incidence of placenta previa and all the consequences that these two major complications of the placenta, anomalies of the placenta, have on delivery. Frozen embryo transfer, blastocyst transfer is associated with reduced risk of placental and cord-related complications, including abnormal cord insertion in the marginal area, placental rupture, preeclampsia, small gestational age, compared to fresh cycle. Thank you very much again for inviting me, and thank you very much, of course, to Professor Gamal Sarour, who is not only a great friend, but also has had an amazing career, and without who we wouldn't be